Hello. I'd like to thank Sages for inviting me to talk about the role of robotic inguinal hernia repair. Sorry we couldn't do this in person. Forgive my scrubs, I'm just finishing up a week ACS call. I do not have any disclosures. So the goal of my talk will be to review the available evidence for robotic inguinal hernia repair, both the initial retrospective series and more recent prospective data that has just debuted in the last few months. All of this has provided a lot of insight into things like OR time, ergonomics, cost, patient-reported outcomes, as well as the learning curve, which we're just starting to understand. Most of this data ultimately attempts to compare the robotic approach to either its open or laparoscopic counterpart in order to justify the use of the new platform. So that's really what the discussion is about. Needless to say, I get the sense that most surgeons have really strong feelings one way or the other about the robot. It's right up there with religion and politics when it comes to things not to talk about unless you know where everyone at the dinner table stands. My goal is really not to pick sides, so I'm going to try as hard as I can to present an unbiased review of the data that exists, and at the end try to come up with some logical viewpoints on where we are right now and where the future prosperity of robotic inguinal hernia repair lies. So robotic inguinal hernia repair was initially described as a procedure that could be done concomitantly with prostatectomy. And eventually it became exceedingly popular amongst general surgeons, what seemed like overnight. The specific theoretical advantages were suture fixation of the mesh and peritoneal flap instead of tacks. And the potential downstream benefit of that was that it could cause less postoperative pain and even require less narcotics postoperatively. And so additionally, many surgeons fell in love with the experience of sitting down while operating, and they began to wonder if the ergonomic benefits could expand the career of a surgeon. And so, some of those things are difficult to measure. Certainly, things like ergonomics and the long-term benefits of that are not easily measurable. And so, most published early experiences mostly focused on demonstrating that the robotic inguinal hernia repair could be done efficiently, and it could potentially have some early benefits in regards to postoperative pain. So as you can see in the first study here, it showed that the robotic approach takes a little longer, but the patients spend less time in the recovery room and then they have less pain than laparoscopic historical controls. Dr. Kudzi, who is truly a machine when it comes to churning out his data, showed in his early experience that OR times were comparable to historical controls, even with increased complexity of the robotic cases. And then finally, the last review here summarizes the experience of seven surgeons at 6 institutions, and they found that the robotic cases took about 27 minutes longer, but ultimately offered fewer complications, mostly driven by fewer surgical site occurrences and infections. Next, we show a table that was taken from a recent meta-analysis, and really I just put this up there to show you the spectrum of OR times that ranged anywhere from 48 minutes to 124 minutes. And certainly, a lot of that's the function of whether or not these were bilateral or mostly unilateral experiences, and as well as the surgeon's experience as well. And so despite wide adoption of robotic inguinal hernia repair amongst general surgeons, there was really nothing more than retrospective reviews up until a few months ago. In March, my partners published the first randomized controlled trial comparing laparoscopic and robotic inguinal hernia repair, and this included 6 surgeons from 4 hospital systems, and many, if not all, the surgeons I think would be considered leaders in the realm of robotic hernia surgery. At the time that the study was designed, there was actually very little data off which to power any primary outcome. For instance, most of the retrospective reviews that I just referenced really hadn't been published yet. And so this trial was designed as a pilot to investigate most of the touted benefits of robotic inguinal hernia repair, and specifically postoperative pain measured by the visual analog scale, health-related quality of life measures as measured by the SF-36, mobility as measured by the physical activity assessment tool, cosmesis was measured by the Stony Brook SCAR evaluation form. And then, cost was looking at OR time, and then disposable reusable cost as well. Ergonomics was measured by an independent observer who used the rapid upper limb assessment tool. And then finally, mental workload was measured by the NASA task load index scale. And again, the idea of the pilot design would be that, for instance, if there was a type 2 error where it appeared that there was something that was favoring one approach or the other, but it was underpowered to detect that you'd have that information, and then you would use that information to power a future trial. So they ultimately randomized 102 patients undergoing unilateral inguinal hernia repair. And the only baseline difference was a small difference in BMI. Intraoperatively, the incisions were expectedly different depending on the platform used, as well as the locations of the incisions as well. What was most striking was really the difference in the OR time that favored the laparoscopic approach by 35 minutes. And in a second, we'll kind of break that down. So as you see on the next slide here, it was really, that time was kind of spread out everywhere. It was 5 extra minutes for the hernia dissection, 5 minutes for the mesh fixation, 5 for the peritoneal closure, 5 more, which was attributed to docking, which was the median docking time was 5 minutes. And then that kind of left about 15 minutes of a miscellaneous time in other specific parts of the operation. But ultimately, it culminated in an extra 35 minutes compared to the 40-minute laparoscopic procedure. Next, essentially all of the patient-reported outcomes were the same. And what was striking was that there didn't seem to be anything that was kind of trending toward a benefit in the robotic approach, and then we were just underpowered to show it. Likewise, the cosmesis scores, the ergonomics evaluations, and the postoperative complication rates were similar between the two groups. What was different was the NASA TLX scores regarding surgeon frustration and effort required to finish the operation, both of which were less favorable for the robotic approach. Regarding cost, the summative findings, again, this is 4 different institutions, showed that the robotic approach had a higher disposable reusable cost by about $1,100, and the cost of the OR due to the increased time was about $500. So ultimately, the robotic approach cost twice as much. Notably, that does not account for the capital costs of either platform. So the conclusion from this analysis was that the robotic approach takes longer, it's more expensive, and more frustrating to the surgeon. And all of this may sound absolutely ludicrous, if you're someone who kind of enjoys the robot and uses it routinely. And to what I would say is there's a couple important things to be pointed out for this trial. First, to be fair, when it comes to OR times, they're not novice surgeons. This is Alfie Carbonell was the lead enroller in this trial, and who is essentially one of the godfathers of robotic hernia repair. And Ajita Prabhu was the second enroller, and she's been at this for at least 4 or 5 years. And so the next important thing to recognize is that these are all MIS trained surgeons with extensive experience in the laparoscopic approach. And I think that their laparoscopic times are much shorter. If you look back at some of those retrospective control arms, their laparoscopic times are very short. And so I think when it comes to frustration, what you have to recognize is that is an emotion that is relative. And so 4 minutes in the operating room feels like an eternity when you have to wait for an instrument that was supposed to be there. And so likewise, 35 extra minutes in the operating room feels incredibly frustrating when you know how fast it could be done another way that you're capable of. And so I think a huge takeaway is not that the MIS trained surgeons who are incredibly proficient with the lap inguinal hernia repair, for those people, it's really an uphill battle to build a better mousetrap, particularly when the theoretical mitigation, if you mitigated OR time and frustration, that still leaves a dramatic cost discrepancy. The next study to discuss was a prospectively maintained database of surgeons, the Prospective Hernia Study Group, that entered inguinal hernia repair data in an expertise-based fashion. So essentially the surgeons were selected to enter data based off their dominant approach instead of a randomized fashion. And then this data would be used to review retrospectively. And I think this is really interesting because it really allows surgeons to compare what they feel is their personal best. They collected data on just over 500 patients before stopping for analysis. And then they propensity matched groups to create comparable arms and allow for comparisons within those groups. And really, this is essentially emulating a randomized controlled trial by creating comparable groups on the back end. And so in the absence of a randomized trial, this is kind of the best you can do. And you see they had pretty good follow-up as well. And so we'll look at the comparison of robotic to lap first. And what they found was that, again, the robotic approach took a little longer, but the difference was really not as dramatic, particularly when you look at the unilateral repairs alone. They're basically the same. And when compared to the rival data, what's interesting is that for the unilateral repairs, their robotic times were about 10 minutes shorter, but the laparoscopic times were 25 minutes longer. And so what this kind of, again, to circle back on the rival trial, what it really underscores is that those surgeons contributing to that study were really, really efficient masters of laparoscopic repair, more than they were inefficient with a robotic approach. And so next, regarding the outcomes of robotic and laparoscopic approaches, they were basically the same in regards to returning to activity, work, quality of life. And the notable difference was that the patients requiring prescription pain meds was higher in the laparoscopic arm. And this is unfortunately, this highlights probably the biggest limitation of this endeavor, which was that there was no standardized pain regimen for these surgeons to provide. They kind of did whatever their standard of care was. And so we really don't know if that difference reflects a difference in technique, or if it really just reflects a difference in practice patterns amongst the surgeons that were putting data in. When it comes to comparing robotic to open, robotic repairs in their database, even after propensity matching, still included more bilateral repairs and more concomitant procedures. So against the groups, they couldn't get them to be exactly the same. So even though that somewhat clouds the OR time analysis, they did find that for unilateral repairs, the OR times in this analysis were actually comparable. In regards to the outcomes, they did find that the robotic repairs returned to normal activity 1 day sooner. They had improved quality of life at 2 weeks, and they required fewer prescription pain medications. Again, with the previously mentioned limitation that prescribing patterns weren't standardized. And so I think a fair conclusion after reviewing this additional data is that, again, there's little difference between lap and robotic, and there's potentially some advantages to the robotic approach compared to open in regards to early pain, return to work, and quality of life. Regarding the statements regarding the benefits in reduction to pain medicine, I really can't emphasize enough how much of a limitation it is that these practices weren't standardized. I'm a member of the AHSQC opioid task force, and I can speak to the wide variability in prescribing patterns among surgeons. And patient consumption, what we found is often a function of what we prescribe and counsel them. So it's really unfortunate this wasn't kind of baked into the bread of the database design, as it could have really provided a lot of valuable insight. Unfortunately, just like the rival trial, that this was just not on our minds 4 or 5 years ago when we were designing these types of things. The way that opioid consumption is kind of at the forefront of a lot of these discussions nowadays. Since we did see a wide variety of operating room times, 75 minutes was the median time for the rival trial. It was as low as 57 minutes in that second cohort of the last prospective hernia group study. I did think it was worth looking at some of the available data regarding the learning curve, and what Dr. Moysums reported was in his 51st cases shows pretty dramatic decrease in the amount of time, suggesting that the learning curve is pretty steep. And then a second report by Dr. Tam of 18 surgeons across 3 hospital systems specifically looked at one surgeon's kind of at the beginning of their experience and found an inflection point at like 11 to 12 cases. And so while it does seem like the robot may have a very steep learning curve, you have to remember that at the time of the publication by Dr. Neumayer, which classically describes the learning curve for laparoscopic inguinal hernia repair as 250 cases, that's commonly quoted. The common understanding at that point was that the curve plateaued at 30 cases, and this is a line from the discussion in that paper. And I think likely it's because they were looking at OR time, just like us. But that really wasn't the way that they determined proficiency. The way they determined proficiency, they had the benefit of looking at recurrences several years later. And so it was only then that they were able to appreciate when a gut operation was being done. And so I think that, again, really underscores just how much more work we have to do to understand not just how quickly you can get a surgeon through this operation, but what is the true quality of that operation. And so where does that leave us? So I think that with the data we have today, I would say that it's going to be a tough sell to get a proficient laparoscopic surgeon to convert to a robotic tap, because for them, it's going to take long, and for them, it's going to be more frustrating without a measurable trade-off on the back end, not to mention the increased costs. But what about the open surgeon who wants to offer his patients a minimally invasive approach, or a way to treat their own recurrences? Or what we talk about a lot less is, what about the surgeon who's doing laparoscopic repairs but is on the learning curve and doesn't really feel like they've mastered it yet and is getting frustrated with the long uphill battle that comes with, overcoming those 250 repairs? If you acknowledge, I think we can, at least for this sake of discussion, operate under the assumption that MIS repairs offer something over open repairs, in regard whether it's earlier return to work, less chronic pain, fewer infections. Their patients could still benefit from offering an MIS approach, and they can't do the laparoscopic repair well enough to appreciate a quicker operation with less frustration. So to them, it's still a pretty appealing endeavor, and I think an important discussion should be had about how to reconcile all that. So for me, I see two theoretical arguments for robotic inguinal hernia repair. First is the possibility that it has a faster learning curve than the 250 cases it supposedly takes to overcome the lap learning curve. And if you're willing to acknowledge that the MIS approach has advantages, then getting more surgeons to offer that sooner does seem appealing, and it does seem like there's some benefit to that. And even with the elephant in the room, which is the added cost, there is something to the added value of getting surgeons through a learning curve quicker and allowing them to do a good operation sooner. But needless to say, we have a long way to go before understanding that learning curve. And you have to remember that it's really not just about how quickly you're doing the operation. I think often that's kind of the mindset we're in. It's not just about the OR time, it's about the effectiveness and the durability of the repair, which we're a long way off, unfortunately, from understanding. Next, it's the means to an end argument. And if you start to get high-level evidence, for instance, that other robotic techniques, advanced techniques like ETEP, robotic TAR, robotic preperitoneal repair, if those start to accrue high-level evidence that they add value, then their increased complexity is going to require basic procedures like lap inguinal to allow surgeons to get up the learning curve so that they can start to work towards these advanced techniques. However, I think the story for inguinal hernia repair is important because prospective data has now shown that retrospective data was often the victim of selection bias. And so I think it's really important to invest in these other prospective studies for these other advanced techniques so that we can see if these basic techniques could be viewed through the prism of being a safe way for surgeons to gain comfort with the robotic experience. And on that note, I would like to thank SAGES for awarding Dr. Prabhu and I the robotic research grant, where we're looking at robotic ETEP versus IPOM to see if there are any early benefits in terms of pain and quality of life. And we're now well underway, and we're randomizing 4 patients for that this upcoming week. So in conclusion, last slide, I do think that the available data, that the pursuit of robotic tap for proficient laparoscopic surgeons is currently not justified. For the same reason that we don't all drive a Mercedes, and we don't all have an iPhone 11, and we don't all eat at an expensive restaurant every night. But too many surgeons, I think, have fallen in love with this operation to dismiss it. And I think that rather than bickering and fighting on Facebook and allowing industry to kind of pit us against each other, that as a community of surgical scientists, we have to come together as a group and work on a way to really define what's happening. Work together to figure out what is the learning curve? How quickly are we getting surgeons through it? What is the long-term payoff of that? And finally, how does that fit into the value equation? And I think that then, as long as we can describe the benefits of the robot in a tangible way, we can not just offer good care to patients, but also sleep at night, knowing that we're being good stewards for responsible care. Thank you so much for your time.